I would like to welcome everyone to this ATS webinar entitled Bronchoscopic Ablation. Is it necessary and is it ready for prime time? My name is Jen Duke. I'm one of the assistant professors of medicine at Vanderbilt. I practice IP, and I am joined by my co-moderator, Jason Beattie, who's a director of interventional pulmonary research at the Beth Israel Deaconess Medical Center. He also practices IP. We wanted to welcome everyone who's on the call right now. We also recognize that this can be a challenging time for others, and so this recording will be available on the ATS website and YouTube within 1 week. And everyone who's registered today will receive an email once that is available. I'm beyond thrilled to introduce our speakers for tonight in this pro-con debate. Hopefully we'll generate some good discussion, but I enjoy the multidisciplinary portion of our group. Our first speaker is Dr. Moishe Liberman. He is a professor of surgery at the University of Montreal. He specializes in minimally invasive thoracic surgery and interventional thoracic endoscopy. He's the director of the CHUM Endoscopic Tracheobronchial and Esophageal Center and was appointed to be the inaugural medical director of the multidisciplinary CHUM Robotic, Endoscopic, and Minimally Invasive Surgery Program. Dr. Lieberman's research interests include new minimally invasive techniques for staging and treatment of lung cancer, including ablation and ultrasound technology in thoracic surgery. He's run over 60 clinical trials at the CHUM in thoracic surgical oncology in the area of neoadjuvant therapy, adjuvant therapy, and surgical technology with novel devices. He's published well over 160 peer-reviewed manuscripts, 50 book chapters, and has been invited to lecture over 160 times, which will make 161 tonight. Dr. Steve Solomon will be battling him in this pro-con debate. Everyone chuckles at that. Dr. Steve Solomon is the Chief of Interventional Radiology Service in the Department of Radiology and also the Director of the Memorial Sloan Kettering Center for Image-Guided Interventions, or the CIGI. His clinical specialties include thermal ablation and cryoablation in the treatment of multiple cancer types, including lung. In coordination with his clinical work, he has several ongoing clinical trials assessing novel treatments for non-small cell lung cancer. His research focus is in developing and improving minimally invasive image-guided treatments for cancer. He incorporates molecular imaging into interventional therapy with techniques that determine viability at the time of treatment, and remains dedicated to his research craft and has over 300 published articles on PubMed when I searched him just a few days ago. So both of these gentlemen incredibly inspiring to an early faculty like myself. With any topic, it's very important that we are upfront with our conflicts of interest, specifically with ablation. These are the relevant disclosures from each of our moderators and speakers tonight. Give you a chance to take a quick look at that. And then overall plan today is to kind of approach this topic from 3 different angles. We will have about 15 minutes of discussion between our 2 speakers on these different topics. Transbronchial lung treatment is a necessary addition to the armamentarium for local treatment of malignant lung nodules. The second will be transbronchial lung treatment is ready for standard care procedures. And then finally, standalone thermal ablation strategies for full tumor killing is the future of transbronchial treatment. So 15 minutes each. We'll try to pause and have some questions after the end of each of these. So if you have a particular question relevant to one of these sub areas, please write it in the Zoom chat. We'll be monitoring it throughout the conversation tonight. And at the very end, we'll have a wrap up as well, where we'll answer any questions that remain. And with that, I'll turn it over to Jason for our first question.
Good evening, everyone. Thanks for your time, Moishe and Steve. It's an honor to be on here with you. So just so everyone knows, along with everything that Jen already introduced, obviously we sort of forced these 2 wonderful speakers into these pros versus cons. And so it's probably going to be more of a discussion, but for the sake of argument, we've at least asked them to, glaze over the pro or the con on each of these issues. So we'll start it off with transbronchial lung treatment. Is it necessary? Is this a toolkit within the treatment of lung cancer and other malignant lung nodules that is necessary, should be developed further? And Moishe, you can take it off the pro.
Thanks, Jason, and thanks, Jen. Really nice to be here and appreciate the invitation. I think it's important to disclose that Stephen and I are actually very good friends, and we see eye to eye on almost everything lung cancer related. So you may not get that much gladiating and more agreeing, but we will definitely take our sides of the pro con. I'll just highlight one of my significant conflicts. I think it's important. I am the chief medical officer of a company that is working on cryoablation strategies for bronchoscopy. So I think it's important that that's clear. My other disclosures majoritarily are not related to this talk. So in terms of the first question, transbronchial lung treatment is a necessary addition to the armamentarium for local treatment of malignant lung nodules. I would say for me, as a thoracic surgeon and an interventional endoscopist, I like to call myself like a wannabe interventional pulmonologist, although I was an interventional pulmonologist before that term actually existed. So I guess I'm sort of grandfathered in as an old guy. Um, we are moving from diagnostics into therapeutics in IP. I think that's really exciting. I think for the people on this call, I'm guessing the majority are interventional pulmonologists. It's exciting to move from diagnostics into the therapeutic arm. There's a lot more responsibility that comes with that. However, I think we're all ready to do that. We see, so I think that there's excitement on the interventionalist side to do ablation because it adds to what we do as endoscopists, but also lets us be part of the treatment arm and not just the diagnostic arm. We see increasing nodules due to detection and screening, patients living longer with cancer, whether it's lung cancer or metastatic lesions to the lung, but also with lung cancer screening, with GGO prevalence and small nodule prevalence, and what to do with all of these nodules. I think we all deal with on a daily basis for those of us that are doing diagnostics and follow up and treatment of these patients, and having endoscopic modalities to be able to not only diagnose but treat these lesions in a hopefully effective way, but also in a safe way, I think is not only the physician's wish, but also the patient's wish. I would say that there's two important parts in lung cancer treatment or lung nodule treatment with ablation through a bronchoscopic route. And that really has come about because of the advent of robotics and real-time imaging, or cone beam CT, or whatever you want to call your intra-endoscopic imaging. So there's two parts of ablation. One is, how do we develop the best, most effective and safest modality for bronchoscopic ablation? And the second is, how do we get there and assure that we're there so that we can treat the patient 100% accurately? I think if you do a navigational or a radial or a robotic bronchoscopic lung biopsy and you miss the nodule, nothing really happens to that patient. Some of them get a rebiopsy, someone get a scan, some of them get surgery, but they're not just forgotten. But if you go in and ablate, you really need to be sure that you're in the right place at the right time in real time at that second. I think that cone beam CT and robotic bronchoscopy has allowed us to potentially ablate. The problem now is, do we have ablation modalities that are safe and effective? And I think we'll talk about that in the next couple of questions. I think outpatient procedures to prevent surgery are not only in the patient's best interest, but also in the payer's best interest. If you can bring patients in, treat them, and then they go home the same day without any incision, without a risk of pneumothorax, chest tube, pain. I think that this is part of the reason that transbronchial treatment is necessary. And I think we all have talked about it. And if you've been to any IP meetings or pulmonary meetings over the last 5 years, everyone talks about diagnosis, staging, and treatment in a single procedure. I don't think we're there yet, but I think we're getting there. And I think it will be very, very exciting for a patient. I hope in my lifetime, I will see a patient who gets a screening CT in the morning and goes home at night without cancer. And that would be phenomenal. I don't think we're there yet, but I think there are many companies that are working very hard to get you there. I think that the reason endoscopic ablation is necessary is because it gives you all of the benefits of bronchoscopy if you can cure the cancer or treat the tumor effectively without the risks of the percutaneous approach. And it's not to put down the percutaneous approach. Actually, I think until now, that's all we have, and it works very, very well. We also have SBRT. We also have surgery. There's also other modalities, but I think for ablation techniques, percutaneous has been done for many, many years with very good results. But the bronchoscopic route alleviates that risk of chronic pneumothorax, bronchopleural fistula, and I think most of us would agree that a small pneumothorax that doesn't require treatment or requires a small chest tube is not a huge complication. As a thoracic surgeon, every patient I treat with lung cancer has a pneumothorax. It's part of the operation, so I don't worry about that. It's the chronic fistulization that makes ablation through the endobronchial route more exciting. And therefore, I think transbronchial lung treatment is necessary and is a necessary addition to our armamentarium. And I hope we'll become ready for prime time in the next few years. I don't think we're there yet, but I think we're going that way.
Thanks, Moishe. Very well said. And I think we'll try to leave time for a rebuttal if needed. And as you mentioned, maybe it won't be a heated debate, but no better person to respond probably than somebody who's been, doing that treatment for lung cancer for decades and more, and come up with lots of novel tricks, both within the airways and percutaneously, right? So, another person who straddles multiple different fields all in one. So Steve, if you were to caution any of us who are trying to develop transbronchial therapy or, sort of cite more disadvantages than we think are, against us, what would that look like?
Thanks, Jason. Thanks, Jen and Moishe. It's a great thrill to be here with you guys and talk about ablation, my favorite topic, especially lung ablation. It's shockingly, it's been almost 25 years or maybe even a little more than that I've done my first lung ablation. And it's taken a long time and a lot of efforts to learn about the things that how this works and how it doesn't work. And while I'm optimistic about the bronchoscopic approach, I do think that there's going to be a lot to learn over the next several years to get this optimized. We're pretty good with the percutaneous. I mean, in some ways, it's a lot easier engineering problem where you just have a rigid needle and you stick it in and you have a lot more control maybe than a flexible instrument. With the arrival of the robots, things are getting much easier and the cone beam CT to navigate bronchoscopically, which is great. I still think, though, that at this point, it is really important to, when you do an ablation, to make sure that you get it all. Doing half an ablation isn't, I mean, there are all people talking about immune effects, blah, 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 but for the most of it, half an ablation of a lesion is really not going to get you where you want to be. You got to say, this is different than the biopsy. We have to get it all or don't play. So I look at every time I treat someone that with the expectation I'm going to get it all. If I don't, this concept of doing a little bit isn't something that I believe we have proof to support. And so when you're doing this percutaneously, I have to make sure that I can sculpt the ablation to make sure that it covers the entire lesion and leaves it, and including a margin. And that's something that's a little bit tricky, even with the robots, to be able to make sure that you get all aspects and all angles of the thing. So that's one thing. I think that we still don't know enough about the bronchoscopic complication risks. Are we going to introduce infections from the airway? When you create maybe it's a fistula to the tumor, is that going to create an infection or not? Are we going to have some kind of vascular injury? That's also something that we don't know yet about. And so I guess, the way the percutaneous ablation evolved, it's sort of this whole notion of the FDA granting us soft tissue ablation, whatever that means, and sort of people sort of stepping along inch by inch. And I mean, the thing that would be wonderful is to have more trials where we can systematically study something as opposed to sort of everybody just flubbing it along. which is the way the percutaneous evolved. That's not always possible, and it's also the manufacturers aren't always in that frame of mind, but it is something that would be beneficial instead of getting 25 years out and sort of still dealing with this FDA soft tissue ablation thing. So I mean, without the concept of the debate, I mean, I'm optimistic and hopeful that we can have more people interested in lung ablation beyond just those of us who do percutaneous. So I think that would be great. I do caution everyone about the complication risks that we need to understand well. I think there have been some discussion or understanding from some trials with Johnson & Johnson or New Wave's bronchoscopic ablation device that led to some problems. So we have to be cautious. And I think the navigation is critical. So that is another part. So I'll stop there and maybe let us move on and answer questions however you want to do it.
Yeah, is it just me, or are there no questions in the chat yet?
Not yet.
Okay. We had some stock questions just in case, and it might be just as interesting to hear you all ask slightly related questions. One that I think is relevant to something that you both spoke to is, the advent of three-dimensional imaging, which is becoming increasingly adopted and somewhat of the standard, particularly for any therapeutics that are being developed for transbronchial lung therapies. Even within the toolkit for 3D imaging, though, there are different devices. There's mobile cone beam devices, there's fixed cone beam devices. Knowing that sometimes the visualization of ablation zones is inconsistent, even with the best imaging possible, do you all have any sense of if that makes a difference for our approach going forward? Should there be a certain standard? Is any of the above good enough?
I'll let Stephen answer because he knows definitely better than I about real-time cone beam CT, though I've done a bunch of ablation cases. But I would just caution that for the pulmonologists and thoracic surgeons on the call, when you are doing these cases for the first 5, 10, 20, or 50 times, you need a Stephen Solomon in the room because they have done this for years and they know how to look at the ice ball or the thermal ablation zone or the microwave zone. They understand cone beam better than we ever will. We're not talking about biopsying a nodule. We're talking about overlapping ablation zones and getting a margin. And you need a Stephen or someone like Stephen in the room with you. I know that when I do it, I have someone there who's done this for years and years through the percutaneous route. The imaging is the same, Stephen, correct? It's just the navigation that's different.
Well, so I guess one question was about cone beam versus regular CT scanning, and I know that advances in the mobile C-arm have come a long way and are very good. I mean, obviously, a regular CT scan will produce a picture much faster than the cone beam. The cone beam is still kind of cumbersome as you iterate and take multiple pictures. That is an advantage of the CT scanner over the cone beam. But the quality of the imaging is probably sufficient on cone beam to do what you need to do, and will continue to get better and better. So I don't know if that answers your question.
Yeah, no, I think that's sort of what I was getting at. And relatedly, a question from the audience is, can the ablation catheter be confirmed as tool and lesion with tomosynthesis? Because it is the case that there are navigational platforms that have come out even in the past several years that integrate with digital tomosynthesis as a frankly cheaper and more readily accessible version of some enhanced imaging. And then the question is begged as to whether or not investigators can enter the therapeutic field with that sort of imaging.
Maybe I'll answer that one first. I would say no, personally. You have a very little margin for error, and you want to also see the ablation zone in real time. I don't think you can see that with tomosynthesis. So for me, especially when we're starting this out, we need to be the best we can be. You're competing with surgery and SBRT and percutaneous ablation. And I would say, let's start with the best. And over the years, then maybe we can figure out easier and cheaper ways to do it. Again, when we start doing ablation, not everyone needs to be doing it. It needs to be done in centers with high volume, experienced teams, uh, with proven technologies, and with teams that know how not only to do the procedure, but to assess who is benefiting from that procedure and who should be getting some other procedure.
Yeah, I agree on the imaging that start out with the best you have, and that probably should be the cone beam CT or regular CT. And then, that give yourself the best shot at it.
Great. So Jen, I think it's probably enough time to go on to question 2. I think there's some other questions from the audience that we can probably plug into the second or third bullet more naturally.
Sounds great. Stephen, Moishe, you alluded to kind of your years of experience, and a lot of the bronchoscopists on the call may be kind of starting to think this way. In addition, you guys talked about this idea of things that need to happen before we kind of move to our second question, which the question is, or the topic of debate is transbronchial lung treatment is ready for standard of care procedures. So maybe take that, but also go into Mihir's question, what do we need to do before this is actually standard of care? And I will turn it over to Moishe, who will take the pro debate first.
Thanks, Jen. I was given the pro, but I'm sort of pro-con-ish. But I will take so I am pro, but not really pro. I'm sort of semi-pro, I would say. I would say, is transbronchial lung treatment ready for standard of care? Yeah, it really depends on the modality and what modality you're using. I would say that thermal, when we're talking about thermal, I refer to that as heat as opposed to cryo. The main limitation is bleeding. Effectiveness is proven. So we know that microwave and RFA, which are heat thermal modalities, do work. They've been working in the percutaneous route for a long time. And the risk of bleeding, we saw that on the POWER study, as Stephen alluded to, using microwave. Actually, in our hands, we felt it was very successful, but there was some bleeding that was unforeseen and difficult to deal with. When you talk about pulse electric field ablation, the real limitation there is the ablation zone size. The ablation zones are very, very small, and the lack of evidence that this actually cures cancer. So I would say that for right now, I don't think it's standard of care, and I would caution that using pulse electric field today without any clinical trials showing effectiveness is to the risk of the physician. When you talk about cryotherapy, we know from the literature it is safe. There's a lot less bleeding because of the cryogen, and you're able to see it very well under CT or cone beam CT. You can also get a large ice ball size. The real limitation in cryo today is that there's no flexible cryo system that goes through a robotic bronchoscope, even though we know that it does work percutaneously. I will talk a little bit about Dan Sturman's question. Hey, Dan, nice to see you're on the line. I was going to talk about it during this question anyways. The abscopal effect is unproven and, in my mind, unlikely to be clinically relevant. I think that probably one day there will be some evidence, minor evidence, that abscopal effects makes a difference in a patient with metastatic disease. But the radiation oncologists have tried to prove for a long time that SBRT has an abscopal effect. We do see inflammatory and immunomodulators with different ablation modalities. You see that much more with pulse electric field and cryo than you will with the heat modalities, because you're not burning the cells and their intracellular matrix and all the organelles. So you see it with cryo, you see it with pulse electric field, but I don't think that there's ever been a clinical trial that showed that it makes a difference for patients to have that abscopal effect, even as an immunomodulator for targeted therapy. But I hope one day somebody will be able to show that. And to Mihir's question, I would say what we need to make endoscopic ablation standard of care is we need clinical trials that show that ablation through an endobronchial route, whatever method or manner or device you're using, gives good long-term oncologic benefit to the patient with 5-year survival studies. And ablation is no different than SBRT or surgery or immunotherapy or induction. And we cannot treat it as just a modality that does soft tissue ablation. We're talking about curing or treating lung cancer or metastatic disease to the lung. And we need to have true trials that show that this works. And I would say that any ablation modality that is being used as standard of care should have an FDA indication for lung tumor, whether it's lung cancer or metastatic lesion effectiveness based on long-term trials. And until then, if we are offering that to our patients, we should be putting them on a clinical trial or telling them that they're getting experimental treatment without proven benefit. And personally, I feel uncomfortable without consenting a patient on a clinical trial giving experimental treatments that have not been proven. But again, that's to each his and her own decision to make.
Yeah, I think it's probably wise for for any of us to sort of tread lightly in the sense that if we're doing this, patients should be aware that it's novel. It's not necessary. I mean, every situation is different, and that just to protect yourself and them with full understanding of what's going on. The immune system is so exciting. I mean, for so many years we've been hoping that we could figure out a way that we could trigger to create this abscopal effect, and we've done this in mice and to great success, but have only sort of had limited effects in patients. I am hopeful that soon or one day we will have some kind of immune stimulant that will really allow us to create an ablation one spot and create an effect on the metastatic lesions. But as to now, we don't have a confident, definite way to make that happen. So that what needs to make going back to the original question, what needs to happen is I think we need some trials. That goes to the percutaneous side as well. We need more trials, and probably the percutaneous trials can actually help. Both trials can probably help each other in making it support the evidence that this is actually a very great modality. We're going to be publishing our retrospective long-term data shortly, which is really wonderful. But again, it's retrospective, and eventually we do need these more prospective studies as well.
Wonderful. We'll call that the con section of this pro-con debate and go from there. Just to piggyback on what you guys touched to, let's get a little bit more granular with the research that's needed. Going to Mihir's point, what level of evidence? Are we looking at animal models? Are we looking at treat and resect studies? Do you think there's a space where IP, thoracic surgery, and interventional radiology partner in a trial together? What does that look like to you guys?
Great question, Jen. I think all of the above in my mind. I think there needs to be animal sacrifice studies. There needs to be animal survival model studies, and that's for safety and efficacy. And then there needs to be treat and resect studies. But the most important studies will be the studies that come after that, which will be human clinical trials. And you have to give kudos to J&J and New Wave. I think what they were doing was correct. And now the trial has stopped, but that's the way to do it. Again, the FDA made them do that on metastatic lesions, and those lesions, those patients all had stage 4 cancer. So it was really more a safety efficacy rather than a long-term efficacy or overall cancer survival study. But it was the right idea. And I think you need all of those types of studies. But eventually, you need studies of lung cancer patients with stage 1 lung cancer in a very homogeneous group on a large amount of patients in multiple centers undergoing treatment, the same treatment with the same modality of robotic or whatever navigational path to the tumor. They all have to be done under cone beam or regular CT. And then we need to have 1-year survival and 3-year survival and 5-year overall survival if you want this to truly become standard of care. And that's what, I spend a lot of my life doing chemotherapy, immunotherapy, and surgical trials. And that's what we have to do to prove those technologies out. This is no different. We're trying to cure lung cancer. We can no longer be happy with retrospective studies and case series. This is prime time. We're not developing a new way to biopsy interstitial lung disease. We're trying to tell a patient that if you come here and we give you this treatment, we are going to probably cure you. And if not, we should be offering them the other modalities, which have been already been used for years and years and are proven. So I would be hesitant to say that, you know, even though I was the pro on that one, that we are really ready for prime time. I think we're ready for clinical trials, and we're ready for new devices, and we're ready for collaboration between pulmonologists, surgeons, radiologists, and oncologists. But I don't think tomorrow, if I see a patient in my clinic, I can offer them ablation off trial with any of the modalities that we have.
That sounded great. I think also that, you know, you're in a lucky position when you're thinking about this, in that you know, it's at the very beginning, let's say, of bronchoscopic ablation, where you can be thoughtful about how to move forward as a field. And thoughtful means by defining sort of standards. Maybe the standards are that you need to do cone beam CT. It needs to be performed, you know, with a robot, or however, you know, these are the parameters that we will accept as a standard. I mean, so many of us in the interventional surgical realm, everybody's their own chef, their own, like, you know, put their own spices in just exactly this way or that way. And you know, this is a chance to sort of standardize some things and say, okay, well, we tried this is the standard approach, and we found X, this is the result. And now maybe we tweak that and we go to the next stage. But sort of being organized about it may end up being very useful, as opposed to everybody just running around doing their own thing.
Very well said. So lots of collaboration, both with our multidisciplinary colleagues as well as our interventional pulmonary and diagnostic community. With that, Jason, let's move on to the third question, and remember to post your questions in the chat.
Yeah, so I'll do my best to revive this question that has certainly been spoken to already. But maybe we can take the slant of early on in this webinar, Steve, you mentioned that some of the safety concerns with transbronchial approach are either unknown or things that you still have concerns about based on your hard-earned knowledge over the years of doing ablation. And so maybe we can at least argue that, you know, some of the modalities that are standardized for percutaneous may not actually have the same potential, perhaps, in a transbronchial approach. And if that were the case, you know, is there more room, relatively speaking, for other modalities of treatment? Dan brought up the idea of, you know, immunogenic cell death and, you know, synergy with systemic delivery treatment. You know, there are some individuals that are looking into additive effects with local radiation therapy, with, you know, various different substances or devices to augment a radiation response. There's a lot of work being done on drug delivery and a lot of innovation within drug delivery. So with the caveat that, you know, potentially predicts a lot of people doing a lot of different things in a way that maybe we don't want to push the field forward in an organized fashion. Do you see any of those other modalities having a little bit more of an equal playing field in the transbronchial approach?
I think there's, I mean, as you mentioned, there are many different things. Dan's working on some viral vectors, and there are other, you're working on the VTP approaches with photodynamic therapy. And there's so many different avenues that we all can go down different paths and hopefully find something that's really wonderful. Back to the sort of either or thing. I mean, I think there are probably not enough interventional radiologists to treat all the lung nodules that exist in the world. And there are probably not enough interventional pulmonologists likewise, or even, I mean, you know, and so we probably are all in this together in a way. And really, it's you know, at one hospital eventually, I mean, once this gets a little bit more down the road, you know, maybe in some cases might be done bronchoscopically, in other cases may be done percutaneously, and they're just, you know, and maybe some hospitals don't have a interventional radiologist who does this, and some don't have an interventional pulmonologist, and so we all know how many lung nodules there are, and so this is probably more than all of us, and so there's room for everybody to sort of work together and find their solution.
Well said. Moishe, any commentary on different
Yeah.
modalities? Anything of an either or?
Yeah, well, I agree with Stephen. I think, when you talk about all of these newer things, viral vectors, intratumoral chemo and brachytherapy seeds and all of these other things, I think those are all exciting, but they're very far off from being ready for prime time. I would say reinventing the wheel is probably the best way to go about something for the long term, in the 10, 15-year range. But if we want something done today, what I would do, and again, I'm biased because as I told you, I'm very interested in cryoablation, but I think it's important. Radiologists have already proven that heat and cold work in the lung for killing lung cancer. So if we can do the same thing and not reinvent the wheel and find safe ways to do that, we know that heat is somewhat unsafe, especially when you bleed endobronchially. When you bleed into the pleura, usually that's dealt with a chest tube and the patient is fine. But when you bleed endobronchially, especially at home, usually that results in death. So heat has sort of moved away from being what we think is safe for the transbronchial route. But cryo, we know works. There has been multiple trials. There is a cryotherapy approved device from Boston Scientific for the percutaneous route. I think Stephen must use it all the time, and we know it works. So I think the fastest way to get there is to use modalities that we already know work. And I think continue to work on all of those sexy ideas with intratumoral vectors and vaccines, and we're working on that as well, and different modalities to augment. But I think that the key is to find a way to, as soon as possible, ablate lesions endobronchially. And I think that really it's going to be cold or hot. And I think whatever can do it safely, and we know they're both already effective. I think that's going to be the easiest way to the goalpost.
Great. We have another question from the audience. Fabian is asking, who in your opinion should fund these studies?
So it's a very good question. Nice to see you, Fabian, on the line. I hope you're well. Who should fund these studies? Well, I think the studies should be funded by device companies and for the beginning, all of the initial studies, the treat and resect, the animal studies, that's always going to be funded in general by device companies. But I think that there is a role for ACOSOG and for other NIH and other large governing bodies who do cancer therapy trials. And you see a lot of these immunotherapy trials are not only funded by pharma, but also by governmental agencies, depending on what country you're in. I think that eventually will come to that. But for the beginning, most of these will be funded by device companies.
So
Stephen?
I agree. I mean, look, I think you described the way kind of it has to be. I will give you another out of the box thought that nobody talks about, but just for fun. I mean, so let's go back to what you said. I mean, the device companies should fund the pig studies and get the thing going and all that. I agree. And hopefully the government NIHs will be able to fund the clinical trials. But in reality, those are very hard to get. And, many, we know how hard they are. Many times, people are not interested in technology like this. This has been the story of my life, where they don't really support this kind of research always. But sort of an out of the box thought on this is maybe the hospitals should be supporting it. I mean, you think what is actually the expense for, or a collaboration between the device company that's providing, you would provide the instrument, but then the hospital ends up charging for things like, okay, we're going to do a CT scan, or we're going to use, Dr. Solomon's going to be his time is worth this much time. But maybe, I mean, those things are sunk costs for them for the most part. I mean, they're not real additional costs perhaps. And maybe those are things that they can chip in and make it not so costly, because otherwise the device companies don't end up making enough money to support all these big trials, which costs could cost millions and millions of dollars. I don't know.
You guys both touched on bleeding with ablation trials, and I know that was a lot of discussion in the US around kind of these patient outcomes that we've recently experienced. How do you, in your current practice, approach a patient on anticoagulation?
So for us, I mean, I don't want to be sticking needles into patients who are still on anticoagulation, so we have to stop the anticoagulation. I use a lot of microwave, and I feel like the cautery stops the bleeding. So I know that's a little counter to what Moishe was talking about earlier, but I haven't seen very much bleeding with ablation at all. But yeah, I mean, it's clearly it's the thing that's scary. I don't know what went wrong on the flexible bronchoscopic microwave that led to the bleeding. Was it a vascular? I mean, you could puncture a blood vessel, you could create a pseudoaneurysm, you could create, that has delayed injury, or maybe the energy was injured the vessel. I don't know what exactly happened in those cases. I'm not that close to it. But the ablation itself is not really the source of the, burning the tissue is not really causing the bleeding. At least that's not what I've seen.
Yeah, I agree with Stephen. I think that when you're doing percutaneous ablation, specifically in the parenchyma, apart from the hilar structures, bleeding risk is probably very low, and Stephen sees that a lot more than I do. But we also here at my hospital take care of the complications of IR, so we see it too, and we don't see bleeding. We see mostly pneumothorax and BPF, so I think that's correct. I think in the endobronchial route, you're often passing very close to hilar vessels. And if you ablate one of those vessels, they often perforate. And when the wall gets weak, they can have a broncho vascular fistula, and those patients can die very, very quickly. I would say that you don't see that with pulse electric field and with cryo, because the vessels are not burst. They're just either frozen or they're getting a PEF treatment, which doesn't perforate vessels in general. In terms of anticoagulation for myself, we stop, like Stephen, anything that's true anticoagulant. We don't stop aspirin, but I don't stop aspirin for any procedure, whether it's surgery or endoscopy or EBUS or EUS or anything like that. I don't think it's really a risk, but any real anticoagulation is stopped.
What about relatedly in terms of safety, as you all have or are designing clinical trials and thinking about the transbronchial approach and how that may differ safety-wise? Are there certain anatomic parameters that you think arguably, or at least for certain modalities, should be respected? You mentioned the hilar vessels, but is there a certain distance that you think is arguable, extrapolating from the radiation literature perhaps, or something like that?
I think the radiation oncologists have become a lot more aggressive, going closer to hilar structures and big vessels with good success. I think we can learn from that. I would say that using a heat-based modality, I think, at least in our practice, when we were doing that trial that's now closed, we try to be at least a centimeter away from a major vessel, meaning a vessel more than 5 millimeters in diameter. With cryo, you don't have that problem. You can freeze vessels of any size. They don't perforate. They just become frozen and then they unfreeze and there's apoptosis. So we don't see that. I don't think there's any worry with cryo. Stephen maybe could talk more. He's done a lot more cryo ablation than I have, and in terms of bleeding. But for heat, definitely 1 centimeter for us. And that's not based on any clinical trial. It's just based on what we feel comfortable with.
Yeah, I mean, obviously, I haven't done much bronchoscopic ablation work, and I'm not as familiar with, those vessels that are close to the hilum that you're puncturing, perhaps, or nearby. So I can't comment on that too much. Percutaneously, we can access most areas and even sort of central areas, and The other thing we have been doing, we created artificial pneumothorax perhaps to move things away from the mediastinum when we want to ablate, and then let it come back so we don't hurt things like, the phrenic nerve, which sometimes could be in an ablation zone that you're trying to hit. So yeah, I guess that's sort of the answer.
Fair enough. Thank you. We have some more questions from the audience. Jen, do you want to take Dan's question?
Yeah, so Dan was asking, we've discussed parenchymal tumors, ablation on that end. Is there any role, either in clinical trials or in the near future, on looking at nodal diseases or nodal reoccurrence?
Good question. I'll take it first. I would say you have to. I think it's very possible, actually easier for us endoscopically to treat nodal disease and hilar recurrence and parenchyma and tumors in the airway. The question is, what is the oncologic benefit? So I think that you need to take it back a step and think of the patient. So I'll give you an example. You do a patient with a right upper lobe tumor, T1N0 gets treated with whatever, it's Steven or radiation or surgery or ablation one day. And 2 years later, that patient comes back with a 4R lymph node that's positive on PET, and you do an EBUS and it's positive. In 2025, would we go back and operate on that patient? Would we radiate that node? Would we do ablation on that node, or would we do chemo and immunotherapy? Most places would do chemo and immunotherapy because they call that recurrence and not stage 3A disease, because it's distant from the initial treatment modality, and we're treating them systemically. So yes, there may be some indications for local ablative therapy on nodes, and I would say more in the metastatic setting. So you have a patient with melanoma or breast cancer, and they have no other metastasis, and they're NED except for some node, and you treat that. But in lung cancer, at least in 2025, we usually don't locally treat nodal disease when it recurs with radiation or surgery because of the lack of perceived long-term benefit, but that could change. And usually we're treating them with systemic therapy. So I would say, it depends on the patient, but I don't know how, even though it would be easy and we'd love to do it, I'm not sure there's a ton of patients that would benefit.
I think that's a very interesting area for, to be a little contrarian here, but that's a very interesting area for a bronchoscopic approach, because you do have access to these areas and the nodes could be a good target. We do have to think about, as Moishe said, what is the true oncologic benefit, but that may be just the way that we're thinking today, and maybe in the future we think differently when we have a modality that can actually do something in that realm. The problem with radiation is they don't usually like to radiate things more than once, and they can cause more damage. And so the advantage that I always say about ablation is that, let us go after the ones that we can and save the radiation for the ones we can't, because then you can use the radiation. So maybe the nodes are an area that you can ablate bronchoscopically or endoscopically, and then save the radiation for later. But it is something, as Moishe said, we have to figure out, is there benefit to the patient, not that just we can do it, so we do it. And that will have to be played out in the future.
We had a chat question come in about how do we confirm the ablation field in real time for cellular death? Is there any way besides CT? And maybe I'll add on to that question and just ask you both, how are you following these patients long-term currently in your practice?
And Steve, this is when you don't have an inter-procedure PET.
I'll let Steve take this one first, because I think he's got a lot more experience than me.
And I wasn't sure. I figured I'd show you this picture just because I have this. Sorry, Moishe. I did have this. I pulled this up. So let's see if this will work here. Share this picture here. So this is. Let me make it big here. Okay. So this is a picture, like, for example, of a lung nodule as a metastasis. I totally don't know what this is, why I did this or what this is about. This is the ablation. This is real time, and you can see that there's this halo around the target, and that's we can see this within minutes of the ablation. And this is a good surrogate marker that we've killed this zone and have a margin around this little nodule. And so that's sort of what I'm using in the procedure suite. And you can see that on whether, similarly with cryoablation, you can see the ice ball and you can see that you've covered it, or the heat, you can see that. And you can see it with cone beam CT, and you can see it with regular CT. And that's sort of in the room what you use. We don't really have a great tool for knowing viability so much the way maybe you would dream it would be. I mean, but this is not a bad marker to see. In terms of longer term follow-up, I usually like to get a CT about a month after the procedure, kind of looking for complications, but looking for baseline, to set a baseline. And in that month, you'll see the zone that becomes even more clear that I just showed you. Actually, it's within 2 weeks, you'll see a really nice halo around the area that you treated. And then over the next few weeks to months, you'll start to see that consolidate. And then over months after that, it starts to shrink down and get smaller, and then smaller and smaller over time, leaving a scar behind. The FDG activity also goes away, and then you'll be left. There'll be an inflammation ring around the lesion, but that's sort of like the ring that we just talked about. You can use other biomarkers, whether it's somebody put in the chat here, I see ctDNA, and that is another thing that we've looked at in other proteomics tools to look at whether or not you've been successful. Sometimes though, we worry that some of these could be artifactual from the destruction of the cells themselves. So if you're looking immediately afterwards, there could be a big spike as things are released, but then subsequently go down, and that's an area that we need to evaluate further.
I'd agree, and I really love the image because it looks like you cut that tumor in half, Steve. There's like a hollow core right within the tumor.
The black line is the needle track, and it's the cautery of the needle track that you're seeing.
Yeah, it looks great, especially in that tiny little tumor. So awesome shot. I agree. ctDNA would be a great way to follow these tumors, and tumors that were ctDNA positive pre-ablation in the long term. And I think that ctDNA is evolving very, very rapidly, and we're going to be using it more and more over the coming years.
And then we were thinking maybe just one more question. Maybe Moishe, you could start off with this, because I know you've looked into techniques related to this. Question from Arman about the limitations of just having the ability to deploy one device bronchoscopically, whereas IR has the benefit of deploying multiple needles, what have you. So what are some of the technical aspects of trying to optimize things bronchoscopically?
Yeah, I think that there's a common misconception that bronchoscopically you're sort of limited to the airway, and with that you can really throw out only one device. I would say our experience is on almost all of the ablations that we've done, we're going cross country with the robot. So we exit the airway as close to the lesion as we can, and we just drive within the ocean under cone beam and get to the lesion. And then if we can't get right in the middle like Stephen did, we will do one on either side, depends on the size of the lesion. You can do 2 or 3, obviously not at the same time because the robot is holding the catheter, so you'd have to do one at a time, but we've done that and what we call bracketing the tumor. I think in IR they do similar. The advantage that IR has over us is they can do bracketing sometimes at the same time, so they can put 2 or 3 catheters out at the same time. We have to do it sequentially because we're using one robot at a time. We can't really fit 2 or 3 robots down into the parenchyma at the same time, but definitely doable. And even for larger tumors, you need to do that even if you can get into the middle of the tumor, just to make sure you have a good margin.
Steve, any comments on for that?
I mean, I guess I would say that I would think of that as more of an advanced situation and not recommend starting that way. Start with tumors that you can get with one probe and one shot. I mean, that the nodule I just showed you is a small, maybe silly looking nodule. It's so small, but at the same time, you know, it's very doable and a good place to start, I guess.
So start small and build from there.
Yeah, build from there, get experience.
Yep. A lot of collaboration in our future. But I appreciate everyone coming to this webinar on bronchoscopic ablation. Is it ready for prime time? Sounds like no, but lots of good discussion and some work to be done in the field. I wanted to thank ATS for having us tonight and the folks over there. I hope you're recording this. Again, remember that it will be available in about a week, and you'll all receive an email for that. But I wanted to thank Jason as well as Stephen and Moishe for spending the time with us and all the audience who put forth such great questions. Thanks so much. Have a good night, guys.
Thank you very much. Bye.
Thanks. Bye-bye.